Okay.
Why I cannot mute?
Okay, should I start?
Okay, doctor, we can.
Okay. So let's start recording. Okay. So we will be talking today about what we do with newborn babies. Now, newborn babies, when they born, either they are need some help, or they need no help, or they need intensive help. When babies need some help and intensive help, it's the duty of an ICU. When the baby does not need help, supposed to be the duty of midwives or resus nurse, or not an ICU. So for the NICU, or neonatal resuscitation, we need equipment. And anybody deals with babies and mothers need to be aware what are these, even if they don't use them frequently. So we need, when we deal with babies, we need suction equipment, such as pulp syringe, mechanical suction, tubings, catheter, the pressure. We need the feeding tube to insert. We need 20 ml syringe. We need intubation, be aware about the intubation equipment. We need medications such as dextrose, naloxone, needles, syringes. And we need radiant warmers, we need towels, we need monitors. And also we need, when you need respiratory support, we need other support. Now these it's not your business as a newborn or as a nurse dealing with mothers, but it's okay to be aware of this list. Now, the most important for a nurse dealing with a mother is to know when we call an ICU. And these, we call it risk factors or high risk deliveries. And the maternal conditions that cause high risk deliveries are advanced or very young maternal age. So even if the baby is term, but the mother is less than 18 years, or the mother more than 45 years, an ICU team has to be there. If the mother is diabetic or hypertensive, whether it's a gestational or it's a essential hypertension or secondary hypertension, whether it's a diabetic or it is type 1 or type 2 or gestational diabetes. If the mother have substance abuse or smoking, or she's on medications that can affect the baby. If the mother has a previous history of fetal loss or early neonatal death within 28 days, even if the baby is okay, an ICU team has to attend. So these are maternal conditions that usually occur before the pregnancy. But also there is fetal conditions. If the baby is less than 37, that means he is even 36 plus 5 days, the ICU teams has to be there. If he's more than 40, if the baby is more than 42 weeks, an ICU has to be here. Any suspected malformation, or even after delivery and you see malformation, an ICU team has to attend. If the birth weight is less than 2.4, if it's twin or more, if there is placental anomalies such as placenta previa or approachio placentae, if there is oligohydramnia or polyhydramnia, if there is a delivery complication such as transverse lie or a breech, if the mother has chorioamnitis, and chorioamnitis means mother has a fever, uterine tenderness, leukocytosis, foul smelling liquor, bradycardia of the fetal bradycardia, fetal tachycardia, or if there is antenatal asphyxia. How we know antenatal asphyxia? By number of kick. So if the baby has decreased fetal kick or decreased growth or abnormal Doppler, we knew that there is a pre-labor antenatal asphyxia. And asphyxia means inability of the baby to make or to initiate and maintain spontaneous breathing. That is fetal asphyxia. If the mom is on narcotics, such as for pain, such as morphine, fentanyl, and other narcotics, if there is instrumental delivery, if the baby is compromised in any way, so instrumental delivery like forceps or vacuum, C-section has to be attended by an ICU team. Fetal compromise, all these conditions you have to call. This is not your job. This has to be attended by the NICU trained personnel. Even if all this not there, but the baby deliver and there is meconium, you have to call an ICU. If the baby deliver and he's more than 4 kilograms, you have to call an ICU. If the weight is less than 2.5, if the baby developed a kidney after birth, if you give milk or breastfeeding and the baby is not feeding, if the activity is not good, if there is malformation, if you check the sugar and it's low, if there is cyanosis or color change, all these, even if after
line.
So how we approach, how we know? Now, when the baby delivers, we ask ourselves 3 questions. Simple, 3 questions. Is the baby term? Does the infant has a good muscle tone? Is the infant breathing and crying? Now, somebody said, well, I cannot wait until the baby delivers to know the tone. But you have the risk. When you have these risk factors, you expect that the answer will be yes to one of these. So if these have no risk factor, but the baby will deliver and have no good muscle tone. What is good muscle tone? Is ability of the baby. If you can mute yourself, please. So if the baby cannot take off the hands and the foot off the matrix of the bed, that means the baby is not in a universal flexion, the baby cannot carry the hand and the foot, then he's hypotonic. So when you leave the baby, the hand and the foot is on the bed, on the matrix. And if the baby is not breathing or not crying, it's not the must the baby should cry, but the baby is breathing. If the answer is no to any of these questions, then you need to call an ICU. If the answer is yes, then we don't need an ICU. But the obstetrician has to do delay cord clamping, the baby has to be examined by a physician within 24 hours. The baby should be vaccinated, circumcision if baby need, establish feeding, do newborn screening. These does not need any NICU personnel. If the answer is no to any of these questions, then you need to initiate NRP. If you start NRP and the baby responded, then instead of well baby care, the baby need monitoring care. What is the difference? It is the same, but we will add vital signs every 2 to 4 hours. And we might need to do sugar or a gas or do sepsis workup and so on. If you started resuscitation, you initiate resuscitation, but the baby did not respond, then he needs or she needs intensive care. Now we use this algorithm. I know it's not, you will not do a resuscitation, but you have to be aware of it because sometimes you might be exposed to a situation where you need to do something. So how we assess the baby? We ask the first 3 questions, then we act, then we identify a problem, then we act. This has to be within 30 seconds. So we evaluate 3 questions. Is the baby tone? His tone is good. Is he breathing or crying? Yes, there is problem, intervene. How long this should take? Should take 30 seconds. What we do? So baby born, tone, good tone, breathing, crying. Yes, then routine care. What are the routine care? We provide warmth. We warm the baby. We position the airway. We clear the secretion. We dry. And we continue care the baby. We can make the bonding between the baby and mother. We encourage breastfeeding. and the baby has to be with his mom. We cannot separate the baby for any reason. We establish breastfeeding, but you need to do the vaccination, vitamin K, circumcision if needed, and so on. If the question term, good tone, crying or breathing is no, then we initiate breastfeeding. In the first 30 seconds of NRV is the same of oral routine care. The only difference is you provide stimulation. Same exactly in the first 30 seconds. So evaluate, decide, and act. This should be 30 seconds. So who qualified for routine care? You don't need to call an ICU. Term, good tone, crying or breathing, no risk factor. Who is qualified for further resuscitation? Any baby who is not term, who has no good tone, he's not crying, he's not breathing, or there is risk factor. So how we provide one? Because said routine care, one of the major routine care is provide one. We swaddle the baby. So after the baby born and we dry, we swaddle the baby. We wrap the baby. We might put the baby on the mother's skin to get skin to skin, especially when doing delay cord clamping. We might use polyethylene bag in babies less than 1500. You will not deal with this baby. We will deal. We can use warming pads. We can use pre-radiant warmers, resuscitate. And if we need oxygen, we'll use a humidified heater oxygen. So this way, we have to provide continuous warming of the baby. So skin to skin is enough. Rubbing the baby is enough. Drying the baby is actually warming. So first, in routine care, we provide warmth. Second, we position the airway. So the baby has to be in a neutral position, not hyperflex, not hyperflex. So hypoflex or hyperflex, flexion or extension are both incorrect. How we know? We put the baby in something called sniffing position. So when you do like this, when you sniff, what does it mean? It means that the tip of the nose and the tip of the chin is on the same horizontal level. So we have to keep the nose and the tip of the nose and tip of the chin in the same level. If we make the tip of the nose above the chin, we will be flexing. If we make the chin, the tip of the chin above the tip of the nose, we are hyperextending. Both are causing obstruction of airways. And the baby has to be in a neutral midline position. If we cannot achieve that, we can put a shoulder roll, a blanket or a towel or a piece of sheet, and then wrap it below the shoulder, not below the neck, below the shoulder. By this way, we will align all the upper airway together. So first, we ask 3 questions. The answer is yes, we go routine care. What is routine care? Provide warm, position the baby. Any questions so far? Any question?
All clear, Doc.
No question. So the third in the routine care, we provide clearance of secretions. Clearing secretion only for babies who need respiratory support. You do not need to clean upper airway. You don't need to do suction. Suction causes trauma. Suction causes bradycardia. And suction takes important nutrition from the baby. Even if it's junk and blood, it's a good nutrition. You don't need to take it out. So to do suction, first you need to provide warming. Second, you need to provide positioning. And third, you think the baby needs respiratory support, then you do suction. You use the bulb syringe. How we use it? You squeeze it. Then you put it in the nose. Then you release it. Then you take it out. Then you squeeze it to take the junk out. And then you repeat. You can use mechanical suction. 99% you don't need it. And if you don't need it, you don't section the esophagus. You don't section the stomach. No need. It's harmful more than, even if there is blood, more than beneficial. So 3 questions: warming, positioning, section. Then you need to dry the baby. So you have to prepare at least 3 to 4 sheets. So first you rub the baby with it, dry the baby, remove it. The second one, you dry, then clean the rest of the area, and then remove it, and then you rub the baby by the other one. Once you dry the baby, you actually provide warming. Then the fourth one or the third one, you can wrap the baby with. So 3 questions: term, tone, apnea, not breathe, not crying. If the answer is no, then routine care. What's routine care? Positioning, warming, drying, and warming. So these are. The final step is stimulation. You only need stimulation if you initiate NRP. If the baby is in routine care, you don't need stimulation. The stimulation has to be gentle. If the baby is not breathing, hitting the baby hard will not allow him to breathe. If the baby is not breathing, he needs ventilation. So you need to slap the sole gently, or you need to flick the sole gently, or you need to stroke it gently. You can rub the back on. The rubbing is by hand, not by a harsh towel, by hand, and it should be up and down, not from side to side. If these not allow the baby to cry or breathe, then the baby need PPV. You always need to support the head. You are not allowed to make the body above the head, even if there is secretion. You always has to support the neck and the head. You cannot carry the baby from the leg. This is very dangerous. And I've said this one time, you should not do that. And he told me, or she told me, what is the evidence? I said, well, the evidence, let me carry you from your leg and you will see the evidence by your eyes. It can cause permanent backache to all the life. You cannot carry the baby from the back. This is, for people who does not know who's this is the respected Virginia Apgar, the anesthesiologist from USA who invented the Apgar score. She passed away 4 years ago. She's carrying the baby upside down. This is not accepted. Don't carry the baby from leg. Spelling error. Do not squeeze the chest. Do not rub the chest. Do not rub the abdomen. Do not carry the baby from leg. Do not abduct the leg on the abdomen. Do not hit the bag. This all are wrong practice, and it is very harmful. So, birth, 3 questions. Routine care, no. Initiate NRP 30 seconds. With the routine, you do stimulation. After 30 seconds, you ask now 2 questions, not 3. You ask, is there apnea or gasping, or is the heart rate below 100? You don't need to count heart rate. You just need to say, is it above or below 100? If yes, then the baby need PPV. Once he need PPV, then he need saturation and ECG. And this is NICU work. If no, there is no apnea, there is no gasping, and the heart rate is more than 100, ask yourself, is the breathing labors? Are the baby using accessory muscle? Is the color is not good? If yes, then you need to position, clear again, supplement oxygen, and you might need CPAP. If the answer is no, so for example, the baby, after stimulation, baby improve, then you need a monitoring care. A well baby care done by a midwife is not acceptable here. The baby has to go to a room where we monitor the baby. This is the indication. This baby needs stimulation. So babies, normal babies, they should stay with their mother. So what do? We do the delay cord clamping is a must. And then we check the vital signs. We might need put sat monitor. We might do sugar. We might do a gas. We might do sepsis workup. It depends on the situation. If the baby is not apneic, not heart rate, but he has labor breathing, then obviously he needs respiratory support, CPAP or oxygen. If the baby is apneic or gasping, a heart rate less than 100, then you need a positive pressure ventilation. If you do positive pressure ventilation, you need saturation monitor, you need ECG monitor. So what is apnea? Because you say baby might be apneic. Baby apnea is cessation of breathing for 20 seconds or less than 20 seconds, but associated with heart rate less than 100 or cyanosis. So this is the second step, the 2 questions. Remember, birth, 3 questions, 30 seconds, 2 questions. What is gasping? Gasping is occasional breath, but there is no flow. There is no air going in and out. So you see the breathing, but there is no air going in and out. There is no exchange. There is no actual breathing, but there is chest movement. So either occasional gasp, or occasional movement without flow in the upper airway. What is heart rate? You check the heart rate over 6 seconds and by stethoscope, not by palpating the umbilical cord. And then you multiply it by 10 seconds. So you have to have at least 10 per 10 seconds. If you have more than 10 per 10 seconds, then you're okay. If less than 100, so you just need at this second level, at 1 minute of life. Because remember, at 30 seconds of life. At birth, 30 seconds. You just need above 100, below 100. That's all. You don't need to keep counting. Cyanosis is a blue discoloration of skin and sclera. It should be central, not on the legs and the foot. Labored breathing in difficult breathing. Intercostal recession, suprasternal recession, subcostal recession, movement of Eli nasi, movement of the Ella, the 2 sides of the nose. How we give oxygen? We can give it by simple mask, or we can give it by nasal cannula, or we can give it by flow inflation bag. We can give it by bag, or we can give it by air oxygen blender. And I will stop here. We can continue next session, unless you guys have a question. So next session will continue. And then me and my friend.
When will arrange the next session, doctor?
You arrange it whenever you want. I will record it. I will hope I record it because I prefer I invite you. The reason because I can record it on YouTube easy. So now I have to record it local and then upload it on YouTube. It takes time from me. But you need the next session anytime. Once we complete these sessions, I will provide with materials so people can examine them, how to answer. And then we will do live. Even if you are not carrying a newborn, you need to know that because you don't know, maybe the NICU will be busy. Maybe there will be absence. Maybe you call and nobody comes. So you need to know this in details because you might be exposed to a situation where you need to help a baby. Any question?
Miss Maria and the LVCF has any question?
I can repeat this as many as needed.
Okay, doctor, thank you for your time.
Thank you.
If you can share with us this great presentation, we will be appreciated. And also the PowerPoint, if it's available, we can upload in our education folder to be available for all the stuff to read.
Sure, I will send it to you.
Thank you, doctor.
Thank you very much. Thank you for everybody for coming. Thank you. Have a great night or a good night. Sleep well. Enjoy your rest of night. Assalamu alaikum. Bye-bye.